Hello, welcome to Sonography Radiology Training channel. This series of videos is about umbilical cord imaging. This is the third video in this video series with title of Why You Need to Know About Hyrtl Anastomosis. The outline of this presentation include introduction, ultrasound technique for detection of the Hyrtl anastomosis, types of anastomosis, importance of anastomosis, and final teaching points. At first, introduction. Hyrtl anastomosis, an under-recognized arterial anastomosis, is found in approximately 96% of umbilical cords and has been considered to equalize umbilical artery pressures prior to insertion in the placenta. The discordance in calibers of umbilical arteries is the consequence of a failure of the anastomosis to develop anatomically or to function fully. Moreover, the resistance to blood flow may differ considerably between the two umbilical arteries. This difference decreases as pregnancy advances, suggesting that the equalizing system changes its function during gestation. This image shows high resistance index in both umbilical arteries at 12 weeks gestation. But at 33 weeks gestation, we can see low resistance index and equal in umbilical arteries. In 90% of the cases, the anastomosis is located within 1 to 3 cm of the placental end of the umbilical cord and varies in length from 1.5 or 2 cm and in caliber from 0.33 to 1.5 times that of the umbilical artery. The ultrasound technique for detection of the Hyrtl anastomosis. The detection of the Hyrtl anastomosis requires considerable experience on the part of the examiner and also depends on other factors like the implantation site of the placenta as well as the cord insertion. A target ultrasonographic assessment of the umbilical cord and placenta should be done. The diameter of the Hyrtl anastomosis can be measured as the outer to outer border. Types of anastomosis. There are many types of anastomosis anatomically. At first, it may be transverse or it may oblique. Another type is fenestrated between two umbilical arteries. Another type is fused form. In fused type of Hyrtl anastomosis, we can see two separate umbilical arteries at placental insertion, a fused portion, and also two separate umbilical arteries again. Another type is branched. Sometimes the anastomosis may show branched shape. In addition, sometimes there is only a single umbilical artery and sometimes there is no anastomosis between two umbilical arteries. The most frequent condition, accounting for 80% of cases, is the presence of an intermediate communicating vessel that it may be transverse or oblique between the stems of the umbilical arteries. The fusion of the umbilical arteries before interning the placenta is not an uncommon finding and can be detected in utero by prenatal sonography. What is the importance of Hyrtl anastomosis? The presence of a pressure equalizing system is particularly important during uterine contractions when the blood pressure and resistance in the corresponding portion of the intervillous space and cotyledons may differ in different parts of the placenta. It has been suggested that in conditions of compression and blockage of the arteries, the anastomosis functions similarly to the circle of Willis for the brain and behaves like a safety valve. The role of anastomosis is crucial as pregnancy advances when uterine contractions become more pronounced. As I explained before, with advancing gestation, by changing in Hyrtl anastomosis function, the resistance index decreases obviously. One of the first importance of Hyrtl anastomosis revealed by animal experiments. Animal experiments have shown that when the blood flow is reduced by cord occlusion, significant changes in umbilical artery blood flow became apparent only when the umbilical blood flow is severely impaired. The presence of a buffer system such as the Hyrtl anastomosis allows the perfusion of the entire placenta even when the blood flow in one umbilical artery is completely impaired. Moreover, in fetuses with a single umbilical artery, the lack of this safety valve may partially explain the increased rate of unexplained intrauterine fetal demise in the third trimester of gestation and during labor. The function of the Hyrtl anastomosis is particularly important at the end of gestation when diminution of the amount of Wharton's jelly around the umbilical arteries is particularly pronounced and therefore the risk of cord compression is increased. You can find full explanation about prenatal assessment of Wharton's jelly in this video. The second importance. It has been shown that in cases of an oblique Hyrtl anastomosis, the artery into which the anastomosis empties supplies a larger area of the placenta, and the size of which is proportional to the diameter of the Hyrtl anastomosis. This study, by utilizing angiography, showed that in cases in which the diameter of the anastomosis at least equaled that of the umbilical arteries, they supplied a mean 26% and 74% of the placental areas respectively. This image shows an asymmetric placenta with a need for shunting. As you can see, 31% and 69% respectively of the area is supplied by each umbilical artery. The diameter of anastomosis is 4 mm, which is wider than both umbilical arteries in the cord. At the cord insertion, one of the umbilical arteries widens to the same diameter as the anastomosis. In cases in which the diameter of the anastomosis was smaller than that of the umbilical artery, they supplied mean placental areas of 41 and 59% respectively. As you can see in this image, about 41 and 59% respectively of the area is supplied by each umbilical artery. But the anastomosis is narrower than the umbilical arteries. Interestingly, in placentas lacking a Hyrtl anastomosis, the two umbilical arteries supplied 45% and 55% respectively, indicating a relatively high degree of symmetry. This image is related to a placenta without Hyrtl anastomosis. Contrast through one umbilical artery does not fill the supply area of the other one. Subsequent filling through the other umbilical artery shows that the two umbilical arteries have nearly perfectly symmetric supply areas, about 47 and 53% respectively. Note that there is no anastomosis and the umbilical cords in different positions in image A and B. Finally, they conclude that the occurrence and variation in appearance of anastomosis between the umbilical arteries in placentas from pregnancies resulting in an appropriate for gestational age infant show that the width of the anastomosis is related to the degree of placental symmetry in respect to the size of the supplying areas of the umbilical arteries. Third importance, increasing evidence demonstrated that the absence of Hyrtl anastomosis is frequently associated with the presence of discordant umbilical arteries. Also, the resistance to blood flow in discordant umbilical arteries may be dramatically different in the third trimester of pregnancy with an abnormal flow in the hypoplastic vessel. This study developed a computational model for quantitative analysis of hemodynamic characteristic Hyrtl anastomosis in cases of blood flow discordance in the umbilical arteries. These authors found that when placental territories of one umbilical artery force increased resistance to the fetal blood flow, Hyrtl anastomosis redistributes blood in the second umbilical artery and reducing the high pressure gradient in the affected artery. Conversely, when one of the umbilical arteries conducts a smaller blood flow into the placenta and a relatively smaller pressure is developed, Hyrtl anastomosis rebuilds the pressure gradient in the affected umbilical artery, redistributing blood flow and improving placental perfusion. The results of this study clearly demonstrate the important functional role of the Hyrtl anastomosis in regulating arterial blood flow in discordant arteries to equilibrate the pressure gradients in the arteries before insertion into the placenta. Now, please let's back to our question. Why you need to know about Hyrtl anastomosis in clinical practice? It's better to review a teaching case together. A 27-year-old pregnant woman at 36 weeks gestational age referred for evaluation of fetal growth and color Doppler study. As you can see in this image, the femoral length was normal. Head circumference and also biparietal diameter are at normal range. The abdominal circumference was normal also. So, we have a fetus which is appropriate for gestational age, and there is no evidence of fetal growth restriction or small for gestational age. You can find full explanation about fetal biometry in these videos. In color Doppler study, we found normal low resistance flow in umbilical artery, normal flow in venous duct with positive A wave, and also normal high resistance low diastolic flow in middle cerebral artery. In left uterine artery, we found low resistance high diastolic flow. But as you can see in this image, we found in right uterine artery an abnormal high resistance low diastolic blood flow. You can find full explanation about fetal growth restriction and small for gestational age fetuses in these videos. In a fetus with body weight appropriate for gestational age and normal color Doppler studies in all arteries, why there is an abnormal high resistance flow only in one uterine artery? The answer is here. The placental territories of right umbilical artery first increase resistance to fetal blood flow, but the Hyrtl anastomosis redistributes blood in the left umbilical artery, reducing the high pressure gradients in the affected artery. Thus, it's apparent that Hyrtl anastomosis may play a formidable function, especially in context of compensatory prevention of prenatal fetal compromise due to vascular placental insufficiency. So, we can ignore the only high resistance flow in one uterine artery of a fetus which is appropriate for gestational age and normal in other respects, and there is no need to report it to avoid unnecessary anxiety for the pregnant mother. Notwithstanding, prenatal sonographic depiction of Hyrtl anastomosis is not currently applied and remains an investigational tool. Now, please pay attention to these final teaching points. In conditions of compression and blockage of the umbilical arteries, the Hyrtl anastomosis functions similarly to the circle of Willis for the brain and behaves like a safety valve. The presence of a buffer system such as the Hyrtl anastomosis allows the perfusion of the entire placenta even when the blood flow in one umbilical artery is completely impaired. The occurrence and variation in appearance of the anastomosis between the umbilical arteries in placentas from pregnancies resulting in an appropriate gestational age infant show that the width of the anastomosis is related to the degree of placental symmetry in respect to the size of the supplying areas of the umbilical arteries. The important functional role of the Hyrtl Anastomosis is regulating arterial blood flow in discordant arteries to equilibrate the pressure gradients in the arteries before insertion into the placenta. And finally, it's apparent that Hyrtl anastomosis may play a formidable function, especially in the context of compensatory prevention of potential fetal compromise due to vascular placental insufficiency. Now, I suggest two others of my videos that are close to this video in terms of matter. And thank you for your attention.